Perfect. Guys, we are Team Health E, and we are going to transform primary care, and actually we're going to transform more. So this is the warm-up act, all right? Primary care is just the start. Basically, we thought, what's the biggest problem that we have? Like, what is the biggest thing? Let's push the boundaries. And we realised that really too many patients can access primary care when they need it because the front door is broken. I mean, we've already had several presentations that point out how difficult it is to access. We've all felt that rush on 8:30, and we know how frazzled our primary care. Just look at the GPs around the room, how frazzled we look. So there's a huge serious issue though, because there's a real impact on delayed care. Nigel works with very impoverished people who don't have good traditional access to care, and actually people just get frustrated and they don't access it. So you've got a delayed presentation, we're catching cancer later, like that's how serious. We're catching people at the point where actually they need hospital care, not primary care, or not even self-care, not forgetting our wonderful community services. So there's consequences for patients, but there's financial implications. If you are able to be self-cared, community cared, that is much more efficient for us as a single resource. We're all citizens with a single resource and what we can do to deliver care. I'm looking at the clock as well. So there's huge financial of us doing the greatest good in our healthcare system. Was there not a little bit of that slide? But yes. Look, we really spent a bit of time analysing the patient journey, and do you know, the more we thought about it, actually patients have difficulty accessing all care throughout the system. There's a real, people from the GP saying, when's my appointment in hospital? Okay, so what we said is, let's make this bigger, and let's build what our colleagues said couldn't be done in one day, and we did it, all right? So, yes, we built the smart triage for delivering right care, right place, first time, okay? And already we're getting excited, but we did more. We took contextual patient information, so we had a team building out APIs so we can pull information from AMOS, we can pull information in Compass. This tool knows you. It knows your past medical history, it knows your context. And actually, we built it in that it can speak your language and it can actually deliver information or ask questions in a way that's literate at your level. So it knows your age, your demographic, and it can deliver questions that allow you to communicate in your language to the model, okay? Now this is a bit techy, but I'm going to try and bring you through it and you're going to be excited, it's okay, okay? 136, okay, just forget that, I'll come back to it, ask me a question about it. But we wanted to show, and this is what was killing us, is getting the videos working, but it doesn't matter. We're gonna, okay. So basically we created two modalities. I know people don't like phones, but we created a phone, speech to text, ask me about it, I can show you it. But we wanted to show a demo so it can have a conversation with the patient. It's gonna ask a few questions, it's gonna elicit it. But we wanted to be safe, so if there's a safeguarding concern, it's going to kick you out straight to someone to talk about it. If there is a mental health crisis, it's going to kick you out straight to talk to someone who needs to know about it. This one is actually showing that we have a patient context, so actually you've identified who you are, you've had a fall, bumped your head, but actually you're an 80-year-old man on a pick span, so it knows that that's really important. And actually if you are a higher risk, so even if you're fine, it's not just concussion effects, it's not a head injury effect, it's going to put you into a direct GP urgent call to say, actually this is a fall on a pick span, this is pretty serious. I'll even ask or recommend sometimes 999 because we just thought let's push the boundaries of what we can do. And it's going to ask, are you actually able to phone or do you need someone to phone? And our GP receptionist can phone you back, check you're okay and phone it on your behalf. That's how good we got that model. Right, 23 seconds, quick, next one. Okay, you got it. So, we don't stop there, okay? Keep clapping so that over the people, I'll keep talking. So it's going to pull that information into a standardized format. It's going to red, amber, green, clinical triage, so you're going to be able to see what works in front of you. Next slide. It's also then going to listen, so it knows your context. It's going to listen to that consultation you have with a doctor. It's going to know the triage context. It's also going to look up expert guidance. So as you're talking to it, it's going to fire the GP some nice sound guidance. It's also then going to make a note of it. It's going to read a patient summary, so it's going to give you a summary back to it. Ask me about it. Oh, I keep it, mate.
You keep that one, and I'll take this one. Okay, well done. Oh, did you want to ask a question? Oh.
Hello.
Hi. If you're using this kind of very sensitive data with an AI model, both on the side of the patient and of the staff, how do you ensure that this data is private and protected, especially from third parties and etc.?
Yeah, so David's going to correct me because I'm going to... But so what we have is we're trying to use MCP, so effectively it'll only fill in the data that it needs to draw contextually in a sample, and it will not store it, so will draw and reference. So there's a degree of login and account recognition. So the model will actually ask you who you are, what your name is, and what your agency health and care number is. And yes, we would probably put it in a login, so there's a citizen identification to make sure it's pulling your data when it's you. Okay, so there are aspects of that, and again, we could use a PIN or a passcode to protect that. David, are you having enough of that? Sorry, Jen.
Just one more thing. If there was a large language model attached to it, it would be hosted internally, and the data would actually not leave the environment of the trust or wherever we decide to put it.
Absolutely.
So would this remove the need for like coding your patients and all of that?
Thank you. Yeah. So that's brilliant. I mean, not that we didn't have time to talk about it, but it's going to give you a doctor summary. It's going to SNOMED CT. So data is going to be the oil. So it's going to improve our coding. That's going to improve the tapestry of which we do research on. It's going to do the tapestry with we commission care. Look, I mean, I don't know if anyone's interested in neighbourhood models, but this would be a really good but it's also going to help. It's going to provide a summary back to the patient of actually what happened at consultation. So what's your follow-up? This is quite agentic, so you can plug into it. This is your HACE area of healthcare. This is your front door. So actually, you could say, hey, what's my waiting time for that orthopedic? It can go into Encompass. It can look at that information and surface that back to you. So
what did you get built this weekend, and what is
full
next?
Full stack. We have UI, we have APIs, we have background infrastructure. It's all working, and we have got JSON output into the Triagio model. It all works. We built it in 2 days. People said it could be done, but we did it.
Well done. Any other? 32 seconds for another question.
Okay, so you said it couldn't be done. So
I didn't say it couldn't be done. Someone else did it.
Yeah. Anyways, so my solution was to do not replace humans. The triage should be still done by a human. My solution was to just increase the output through doing the cumbersome tasks.
Yeah, no, it's good. It's 10x when we did 20.
Yeah. So, and my question is, how do you ensure it's actually correct? Because AI hallucinates.
Yeah,
it doesn't know the nuances. Cannot connect the dots sometimes.
Thank you. We train on a closed garden data set, so it doesn't really go out to the wider LLM. We make sure it covers temperature. It's very, very low, so it already looks at the data we give it, and a lot of training.